Hi everyone, my name is Antoinette Lantican and I'm a rising Filipino junior in the University of the Philippines Cyril High School, and I'm glad to be presenting to you here today my study on machine learning on simulated data for predicting SSRI response and depression. A little more about me is that I also serve as the lead coder for the Spectrum of Support and the Undersecretary General for Academics, Research, Training and Development in the Southern Luzon Model United Nations Conference 2025. Also currently on my school break before my junior year starts. A little more so why I'm doing this specific studies because of the fact that I started off my high school journey being diagnosed with major depressive disorder, which really helped cultivate my passion and motivations to study and research more into SSRIs and advanced solutions in mental health equity, especially in such a time where I believe that depression is really a growing public health crisis that we need to address because of the fact that it affects over 100 million people across the globe, and its impacts are also not proportional because it affects more those people that have lower socioeconomic backgrounds and low resource settings. And selective serotonin uptake inhibitors are the most commonly prescribed first-line treatment for depression, and while it is accessible, its response rates vary due to genetics, environment, and healthcare access. There are a lot more things that play into it, like things like, can this person actually sustain prolonged treatment? Can this person afford going through multiple medication trials across different classes of SSRIs just to see which one works best for them? All of those things. Hence why there's actually a need to cater and tailor more personalized, SSRI prescriptions for depression patients. And fortunately, AI is emerging as a powerful tool to predict SSRI response, reducing trial and error treatment, and advancing equitable and personalized mental health care. Now, this is particularly true because there are a lot of things that AI can see that we can. Machine learning models and deep learning algorithms are able to analyze and study a patient's genetic and clinical profile, previous treatment responses, speech patterns, language cues via natural language processing, gut microbiome data, subtle clinical patterns in EHRs to predict in which specific antidepressants are they most likely to respond positively to. This is especially crucial because it's an underdeveloped field. It's a very emerging field of study, and I believe it's worth investing more research and study into it, moving forward with the idea that there's also a need for more ethical frameworks to guide us into it, because we do understand that we're applying AI in such a field that is as sensitive as mental health. Now, this is why I came up with this study with the goals of addressing challenges in real-world data availability, building a predictive framework using machine learning, combining real behavioral data with simulated data to investigate potential predictors of treatment response and differences across simulated treatments. And what I believe makes the study unique is that I combine behavioral data with simulated microbiome and treatment response information to explore personalized psychiatry in such a way that's scalable and practical. I focus on building a proof of concept that's grounded in low cost and more accessible features. Now, I started off my data analysis with a dataset containing real behavioral and psychological assessments, which I used from Depression, Anxiety, Stress Scales, University Student Depression Inventory, and then I used simulated additions, SSRI treatment using 4 common types: treatment response, responder versus non-responder, and microbiome markers. And this was with the goal of exploring SSRI treatment response patterns in the absence of real patient data, because such data like microbiome markers, genetic and clinical profiles are not widely available across backgrounds, because this is particularly the reason why predictive tools in SSRI treatment is also not hugely available, and is also known so little across countries because of the fact that there are a lot of countries do not really have access, do not really have the means of having such vast data sets, at the same time the resources to pull it off. And this is why I believe this study is necessary for that. Now, this is the data that I use. This was the behavioral and psychological data that I was able to use, and then following that was the simulated data that I used. And then next is I cleaned and prepared the data before modeling. Key steps included imputation to adjust missing values, type conversion, feature scaling, one-hot encoding. These pre-processing steps ensured that the data was suitable for model training. And after that, I was able to reconstruct a readable treatment column by identifying which one-hot column was active. And this allowed me to group and analyze results by SSRI type later on, which you will be seeing as I move forward with my presentation. Now, after this, I trained 3 different machine learning models on the same dataset: random forest, gradient boosting, logistic regression, and then I use evaluation metrics like ROC, AUC to assess overall classification quality, accuracy to see how often the model was right, precision and recall to evaluate its balance of false positive against its false negatives, and the 11th score, a summary of those trade-offs. And while the random forest performed best, we have to consider that this was done with very little data, and I believe this only goes to show that this model pipeline can meaningfully pick up on patterns, especially using real behavioral data mixed with simulated variables. In contrast, right, this suggests that ensemble models like random forest may be well suited to capture subtle signals in multidimensional psychiatric data, which is a promising insight for future clinical modeling. Now, to understand why the model makes the decisions, I applied explainable AI for it, particularly feature importance analysis on all of the machine models that I use, and for at least for random forest, these were the top features driving most of the predictions, and we can see that behavioral features and simulated microbiome indicators showed strong influence, while SSRI treatment variables had low importance. Meanwhile, for this one, we could see that it's likely due to a small data set or non-splittable patterns, which was warned earlier during when I was training the model, and this is why there's again the need for more data sets moving forward, like more accessible, more available clinical data sets moving forward. And then for the third one, in logistic regression, the interpretability is built in. A positive coefficient for PHQ-9 change suggests more symptom improvement is associated with being a responder, while a negative coefficient for behavioral distress implies higher distress equals lower likelihood of response. And I guess this aligns with psychiatric insights, and the fact that a simulated microbiome marker also ranked high suggests that the model is capturing biologically plausible patterns even with the lack of real world data. So after this, after training the model, I was able to explore whether it could detect differences in predicted response rates across different SSRIs. And to do this, I grouped predictions from random forest by SSRI type using the reconstructed treatment labels. And I guess this illustrates the model's sensitivity to treatment variation, even with simulated assignment. So I guess this shows how we'd explore differential effectiveness of antidepressants in a real-world dataset. For example, if patients with certain microbiome or behavioral traits consistently responded better to a specific SSRI, we could tailor choices more effectively. Now, moving forward, I would like to clarify that this project serves as a proof of concept, not a clinical conclusion. The simulated SSRI treatments, outcomes, and microbiome markers are not real patient data. Therefore, the model results don't really reflect real-world efficacy. However, the methodology is transferable with real clinical data. This framework could actually support investigations into personalized treatment selection based on behavioral, clinical, and biological profiles. The value of this work lies in demonstrating a flexible pipeline that could adapt to richer real-world datasets in the future. And I was able to take a lot of lessons from recent studies, augmented structured EHR-based modeling with additional behavioral biological perspectives. For the second one, I adapted the multimodal prediction approach using more accessible data types. And for the third one, it informed this study's goal of developing generalizable models for real-world antidepressant response prediction. Now, for this future directions, we must understand that there are still a lot to adjust when it comes to this: validating on real clinical data, expanding multimodal data integration, improving model generalizability, incorporating explainable AI, adapt to resource-constrained settings. Now, these are my references, and thank you very much, GHLC 2025, for this opportunity to present.